I'd like to talk about the surgery-first approach in orthodontic surgery. Last 11 years, we did the surgery-first approach, and we have a good result with this technique. And so today, I'd like to discuss about our experience with you. As you know, surgery-first approach, we can skip the pre-surgical orthodontic treatment or minimize this treatment. And so we can get a good occlusion within the several months after operation. And so the patients are very satisfied with this surgery-first approach. This surgery-first approach has many advantages. Immediately improvement of facial profile can be obtained. And also total orthodontic treatment time can be decreased, reduced by eliminating of pre-surgical orthodontic treatment and facilitating tooth movement after surgery because of the regional acceleratory phenomena. And also possible post-surgical relapse can be compensated within the post-surgical orthodontic treatment. But several disadvantages and limitations are reported. One problem is it is somewhat difficult to predict the post-surgical tooth or jaw movement, and so greater post-surgical skeletal relapse has been reported. Another problem is unstable surgical post-surgical occlusion. And some doctors think that this indication is limited, but after lecture, you can know that these problems is not true. In this lecture, I'd like to talk about how to solve this problem. In the literature, we can see the greater post-surgical skeletal relapse after surgery first approach. Franco reported the relapse rate was 44%, it's very high. And other report also, after surgery first approach, shows a little bit higher skeletal relapse. And so I think these three problems should be solved to get a successful surgery first approach. First problem is how to predict the post-surgical mandibular position, how to predict the skeletal relapse. Another problem is how to control the unstable occlusion. And the last one is how to reduce the post-surgical orthodontic time. If we solve these problems, we can get a very predictable, successful result. Our university team solved these problems, and so nowadays this surgery first approach is the first choice for all dental facial deformity patients. We found that the cause of high relapse rate of surgery first approach is increased vertical dimension. It means that after jaw movement, we can see the increased vertical dimension due to the occlusal interference. But after post-surgical orthodontic treatment, mandibular auto-rotation occurs, like the increased vertical dimension decreases. And this mandibular auto-rotation seems to accelerate the higher relapse rate in surgery first approach. And so, first problem is how to predict and compensate this mandibular auto-rotation effect, post-surgical mandibular position in surgery first approach. But this problem can be solved very simply. This is our protocol. Step one is measure the increased vertical dimension on cast. This technique is very simple. Drawing the two parallel lines on the cast in pre-surgical occlusion state, and then after jaw movement, we can obtain the increased amount of vertical dimension. In this case, vertical dimension is 5 mm, is changing to 8 mm, and so vertical dimension increase is about 3 mm. With this simple technique, we can obtain the amount of increased vertical dimension. Step 2, from this increased vertical dimension, we can predict the post-surgical AP movement. This step is also very simple. Drawing the line from the center of condyle to the medial cusp of the mandibular first molar, like this, and then try to the hinge movement to the amount of increased vertical dimension. This case is increased vertical dimension was 3 millimeter, and so try to hinge movement to the 3 millimeter like this. From under this sectional paper, we can calculate this post-surgical AP movement like this. And then last step is add this predicted post-surgical AP movement to the planned amount of jaw movement. And also, we have to add the skeletal relapse, about 10%. And with this simple technique, we can predict the mandibular auto-rotation effect. I showed one case. This patient had a mandibular prognatism like this, and he had the class 3 canine molar relationship, and the mandible is deviated to the left side like this. The orthodontist planned the day one to the BSS like this for asymmetrical mandibular setback. Together, this mandibular setback, we have to add the mandibular auto-rotation effect.